केस जरा बहुत हाई फाई नहीं है, ऑल्दो कम कॉमन है। The mass in right atrium with pacing leads, क्योंकि pacing leads हम काफी अब देखना शुरू हो गए हैं, ये इतनी रेयरिटी भी नहीं रही। तो मगर कॉमन डायलेमा है कि क्या करें, कैसे देखें, कैसे पहचानें इनको। So preambles are that echogenic mass on pacemaker lead or device lead is about 14%. And thrombus or vegetation, most of the time it's a dilemma. And how to diagnose, how to treat that. Thrombus is about half of the time on the atrial leads, 33% on ventricular leads, and prevalence of vegetation is about 40%, which is again debatable. Is the voice better now? बेहतर है आवाज अब?
जी सर, यहाँ बेहतर है
जी डॉक्टर को आवाज ठीक है?
आप थोड़ी बेहतर है।
हाँ चलिए। So an undifferentiated mass on a device lead can result in delayed or unnecessary treatment. So diagnosis is important. So importance है इसकी, बहुत ज़्यादा rarity नहीं है इसकी, हमने बड़े rare cases देखे। So we start with the case now. थोड़ी सी हिस्ट्री में दूंगा इसका, इसलिए कि ये पेशेंट एक दिन हमारे पास रहा और उसके बाद they left against medical advice. They took their father to फैसलाबाद, वहाँ से आए थे। So 90-year-old male presented with a day or 2 days history of drowsiness, cough, low-grade fever. He had a pacemaker put in 2016. So GCS was 13/15. Whatsoever diagnosis, जो एक दिन में हमारा बना, right upper lung infiltrates, type 2 respiratory failure. He was put on BiPAP. ECG was showing pace rhythm. HRCT showed ILD. His liver functions were deranged. There was some hypokalemia, some sepsis, 13,000 TLC. Platelets were a bit low. ProBNP and TROP both were high, and INR was 1.28. So we did his echo, and this is what we see. I'll go straight to the point where money is. There's an apical four-chamber, and this is a short axis view. इनमें आप देखिए कि there is some degenerative valve changes in aortic and mitral valve. LV function is reasonable, LA is big. But on the right side, you can see the lead coming in, and there is a mobile echogenic mass on or around the lead, kind of obstructing the tricuspid valve and going into the right ventricle. Same thing confirmed from the other view, because this is very important when we are doing echoes, that if we see any abnormal finding, we must confirm in at least one more view that we are seeing the same thing from the other view as well. So you see here, we can see the intra-atrial septum, tricuspid valve, the lead going into the RV, and there is a mobile echogenic mass where borders are not very clear, smooth nahi hai itna. There's something going on there. Again, a four-chamber view, we can see some probably lead-related tricuspid regurg. There's some calcification here, and you can see the mass moving with the lead. So probably it's attached to the lead. It's not separate from the lead. So please remember that my topic is echogenic mass with the pacing lead. So we are not going to discuss vegetations or thrombi or tumors separately. We are discussing these things in the presence of pacing leads. Again, you see here now, pacing lead is very clearly visible here from a slightly different angle. And you see the borders are not very clear. Same thing here, and tricuspid regurg is going at least in two different directions here. The tricuspid regurg velocity is about 2.8. You see here from multiple angles, there's no one clear-cut shape of this echogenic mass, and this seems to be attached to the pacing lead, not attached to the tricuspid valve not attached to the anterior septum. It's almost threatening to dislodge. So, apart from diagnosing what this is, our dilemma is how to treat this condition. So, differentiating a mass on a pacing lead in the right atrium or right ventricle, location is very, very important. Precise location of the mass relative to the pacing lead, if it is attached to the lead or located adjacent to it, it suggests lead-related complications. Distinct from the lead, it could be an independent pathology because there can be independent pathologies otherwise in the same chamber as well. Pacemaker leads are prone to developing thrombi, which can appear as an oscillating mass adherent to the lead, mimicking an infection on the echo. So, this can be the case. Then the size, shape, and texture of the echogenic mass. The shape, texture, echogenicity of the mass can provide insights. Thrombi typically appear as mobile, echogenic structures with irregular borders. The thrombi tend to be smaller and more rounded, like here you see, and vegetations can vary in size and shape, but often appear irregular, elongated, like here, or as probably in our case, because we suspected that to be vegetation. Mobility, we must observe of the mass during the cardiac cycle because it helps differentiate between thrombi, which may move with the blood flow. So these are important pointers, clinching the diagnosis. And thrombi, we move with the blood flow and fixed masses, and thrombi typically have limited mobility, whereas vegetations show varying degrees of mobility, especially with changes in patient position or cardiac cycle. So these are in general true about vegetations, but please remember that we are talking today in the presence of a pacing lead or device lead. Then the attachment site. Thrombi often attach to the lead itself, whereas vegetations may attach to the lead or adjacent structures such as valve leaflets. Vegetations can be mobile or oscillating. Tissue density differ from surrounding tissues. Valvular regurg may be there. These echogenic masses can be infective or non-infective. They may calcify if they are chronic or heal like all other vegetations. Vascular supply is important because we must assess that because the vascular flow within the mass, thrombi typically lacks significant blood flow, whereas neoplastic masses may demonstrate vascularity. Then the integration with the clinical context, as in our case, who had fever, who has raised TLC, so probably all those pointing towards the diagnosis of agitation. So we must integrate echo findings with the clinical history, symptoms, and other diagnostic tests, which can help establish a comprehensive diagnosis. Then serial imaging is very important. We must repeat echo over time to help assess changes in size, shape, and mobility, which may aid in distinguishing between thrombus and vegetations. Because once the patient is put on antibiotics, these vegetation size generally reduce in size, they become calcified. So to differentiate between a thrombus and vegetation, additional imaging modalities or invasive procedures for confirmation like transesophageal, CMR, or PET can be very helpful. You see, there are similar masses, but here the echogenicity is different. This is a thrombus, this is a vegetation. So they look nearly very similar. So these are really the diagnostic dilemmas. Then a couple of points from the literature. This is from the clinical physiology and imaging. Echo findings in patients with cardiac implantable electronic devices. Analysis of factors predisposing to lead associated changes. This was published 2020. There's about 936 cases. T was done prior to transvenous lead extraction, formed at a high volume center, and they analyzed what are the findings in such cases with the pacing leads. The most important echo findings were fibrous binding sites between leads and cardiovascular structures, lead to lead adherence, like in atrial and ventricular leads, excessive lead loops like this, They're generally more common in females than lead-dependent tricuspid dysfunction, asymptomatic masses on endocardial leads, vegetations, and fibrotic reactions within the walls of the heart and veins correlated with the presence of lead loops and lead dwell time. Women were more likely to have excessive lead loops, and the occurrence of loops increased with the number of implanted leads. So there's another paper where they have tried a very novel way of dealing with this kind of mass. An undifferentiated mass on this is published in Heart Rhythm. Undifferentiated mass on a device lead can result in delayed or unassisted treatment. So a novel technique involving a T-guided biopsy of a lead-associated mass by means of a bioptom. This was done. It did not affect the lead stability or integrity and was crucial for determining the etiology of the mass and facilitating appropriate care. So the bioptom and a wire snare can be used. So this was published recently. So just a quick review of the literature, that implantation rate is increasing and over a million implantations were done in 2017 worldwide. Over a million in 2017, and we are 6 years beyond that. So imagine how many number of implantations are there. So we must be looking for these problems. Device infection rate increase out of proportion to the number of devices implanted. Infections can cause device malfunction and clinical complications such as PE and bacteremia. Early diagnosis of device infection and lead extraction within 3 days are associated with decreased mortality. So these are important points. Delay in treating a device infection is associated with a 30-day mortality of more than 5% and 1-year mortality of more than 14%. Owing to poor clinical outcomes in patients with device-related infections, even in the absence of clinical signs or symptoms of an infection, the practical approach is to start empiric antibiotic therapy in patients with a mass on the device leads. So this is very, very important that we must start, like threshold to start antibiotics should be very, very low. And this is my last slide. Echo remains the gold standard for diagnosing pacemaker lead thrombi. CT PET both can be used. Using echo, size, motion, potential complications such as embolization or obstruction of cardiac valves can be characterized and may help guide management. Overall incidence of pacemaker lead thrombosis remains low, but large thrombi attached to a pacemaker lead can embolize, and usually in such cases, probably atrial fibrillation is the cause. So risk of embolization due to pacemaker lead thrombi appear to be small compared to the overall prevalence of these thrombi. When an adherent thrombus is large and causing significant embolization or obstructing of the tricuspid valve inflow, percutaneous removal of the right-sided leads is often needed. And most importantly, the dilemma is what to do, how to treat them. We must start antibiotic therapy. We are thinking vegetations, but still they can embolize. So should we start anticoagulation at the same time? So that is my question to all the panelists and everybody. Thank you.
Shahbaz sir.
It was really a nice case. फर्स्ट थोड़ा सा एक तो कमेंट्स देना चाहूंगा। एक तो पहली बात है कि ना इनके जो वेजिटेशंस या नंबर्स होते हैं उनको डिफरेंशिएट करना इट्स रियली डिफिकल्ट और क्लिनिकल सिनेरियो इज rather more important. If the patient is having fever and other parameters of infection, then you would think about the possibility of vegetation, otherwise maybe thrombus. हमने अपने थर्सडे सेशन में एक केस प्रेजेंट किया था। उस पेशेंट को रिकरेंट निमोनिया हो रहा था और उसको पेसमेकर लगा हुआ था और जो है पल्मोनोलॉजिस्ट का ख्याल था कि उसको वहां से कहीं से जो है ना हार्ट से कोई एम्बोलाय आ रहे हैं और उसको बार-बार निमोनिया हो रहा है। जब उसका ट्रांसइसोफेजियल एको किया गया था उस पेशेंट का जिसका बता रहा हूं कि रिकरेंट उसको निमोनिया हो रहा था, तो देयर वाज वेजिटेशन ऑफ द लीड और इट्स रियली डिफिकल्ट कि उसको किस तरह से ट्रीट करें और लीड अगर पुरानी करनी हो तो उसको मूव करना बहुत डिफिकल्ट हो जाता है। तो बस यही कमेंट्स थे। नाइस केस। शहबाज साहब, थैंक यू।
जी सर, سر میری اس میں کمنٹس یہ ہے نا کہ کبھی کبھی یہ پیشنٹ سیپٹک پلمونری انفارکٹ کے ساتھ بھی پریزنٹ کرتے ہیں، تو ہمیں ایچ آر سی ٹی کو بھی جو ہے نا اس میں اگر ایکس رے میں نہ ہو تو ایچ آر سی ٹی بھی انکلوڈ کرنا چاہیے ایز اے ورک اپ. اور دوسری جو ہے اس ایسے پیشنٹ کو جو اگر کنفرم ہو کہ یہ ویجیٹیشن ہے تو اس میں تو پھر اینٹی کوگولیشن کا کوئی رول نہیں ہے. تیسری بات سر میرا یہ ہے کہ یہ پیشنٹس جو ہے نا یہ کبھی کبھی صرف یہ لیڈ ہی نہیں ہے بلکہ اور بھی وہ ہیں جیسے ڈبل لیومن کیتھیٹرز یا پرمیکیت، تو ان کے ساتھ بھی جو ہے نا یہ اٹیچ ہوتے ہیں، تو ان کو بھی دیکھنا چاہیے اسی میں کہ ان کو کوئی وہ ویجیٹیشن یا کلاٹ یا اس طرح کی چیزیں اٹیچ نہ ہو. تھینک یو
جی
سر.
تھینک یو.